Dr. Randi Libbon is an assistant professor of psychiatry and neurology at the University of Colorado School of Medicine. She obtained her medical degree at the University of Arizona, Tucson, and did her psychiatry residency training at the University of Colorado. She now works as the Director of Behavioral Health Services for Non-Epileptic Seizures Clinic and Epilepsy Division. She has been with the University of Colorado since graduating residency in 2017, focusing her efforts on the psychiatric care of patients with non-epileptic seizures and epilepsy. She is particularly interested in the overlap between the effects of trauma on the presentation of non-epileptic seizures. She focuses her clinical efforts on teaching a range of students, from medical students to psychiatric nurse practitioners and residents, as well as having a passion for teaching mental health providers in the community about NES. With this education, she hopes to improve the care management of patients with NES. She began her interest in this topic as a first-year resident rotating on neurology service and focused her residency training to gain more knowledge and expertise in treating patients with NES. Now I will go ahead and turn it over to Dr. Libbon.
Great. Thank you so much. I'm very happy to be here and I appreciate the invitation. So yeah, as Larissa said, I'm totally fine with you jumping in if questions come up in real time. And then if not, certainly you can ask at the end during the question time as well. All right. So today I'm mainly going to be talking about what non-epileptic seizures are, how they're treated, and what is important to know about non-epileptic seizures that I think, especially from a treatment and practical standpoint, can really benefit people to know if they're trying to get treatment for non-epileptic seizures. I thought I would just ask you if anybody is open to sharing, and if not, that's okay too. If there's anything you already know about non-epileptic seizures, or if there's any specific questions you were hoping to get answered during the presentation today. And I cannot see all of your faces, so if okay, nobody has questions yet. Okay. So this is an interesting name that I use, non-epileptic seizures. And over the decades of people being diagnosed with a lot of different disorders, the diagnosis of non-epileptic seizures has been given a lot of different names. And this has been a point of confusion because when people try to look it up online, a lot of the literature and papers that are written about this topic are showing all these different names. And I find that patients get pretty confused. So why do we call it specifically non-epileptic seizures? Well, epileptic seizures are when the brain is having electrical abnormalities and the body can be having all these different symptoms, movement symptoms, sensory symptoms. And then loss of consciousness or no loss of consciousness. And so non-epileptic seizures can present exactly the same. It can look exactly the same in the body. But when someone's being monitored with an electroencephalograph, an EEG, where they put the electrodes on your head, if the body looks like it's having a seizure and there's electrical abnormality, that's an epileptic seizure. And if the body looks like it's having a seizure, but there's no electrical abnormality, that's a non-epileptic seizure. And the reason I like that term the best out of all of these is because it just describes what it is. It's a seizure that doesn't have, electrical or epileptic activity. Other people like to call it different things, and I try to just call it whatever the patient wants it to be called and whatever makes them feel most comfortable. I don't like to use, all these ones crossed out in red. I really don't like using anything that starts with psycho or pseudo, mainly because, patients hear those words and they make assumptions that the doctor might not believe them or thinks that they're crazy or that it's all in their head. And those things are definitively not true. And so I don't use any of those terms in my clinical practice. So I want to give you some context that non-epileptic seizures are a smaller piece of a broader diagnosis. And that diagnosis is called functional neurological symptom disorder. And specifically for non-epileptic seizures, it would be with the specifier with attacks or seizures. But essentially, the way that functional neurologic problems develop, whether it's seizures or a movement problem or weakness, imbalance, vision problems, we think that the etiology or how it developed is all pretty similar. So that's why this kind of broader category can be an important factor to keep in the back of your mind. With things like seizures, a lot of times the care that someone gets when they go to an emergency department is different than somebody with a tremor, or different than someone with vision loss or gait problems. And a lot of times it can be more dangerous because a lot of times in order to stop a seizure, emergency departments will administer a lot of medications, all of which do not stop non-epileptic seizures. So I think it's helpful to know that any neurologic symptom can have the same kind of place it came from, that we don't right now have a definitive physical cause that we can pinpoint to the symptom. For instance, like, no problems in the muscles, no problems in the nerves, no problems in the brain, like that. There's nothing that we can test and definitively say that there's a problem. We think that it's more of if you were to compare like a computer, it's got the hardware, like the hard drive and keys, and that's like something you can physically see and touch. Similar to like if someone has a brain tumor, you can physically see that on an MRI. NES, non-epileptic seizures, or functional neurologic symptom disorders are more like a software problem where it's not operating correctly. The brain and the body aren't communicating correctly. And another pretty confusing part is that all of these disorders are diagnosed by neurologists who know, can I connect a physiologic cause with the symptoms I'm seeing? And so it has to be diagnosed by a neurologist, but then all of the current treatments that we have are behavioral health in nature, meaning that mostly that's therapy or treating underlying psychiatric comorbidities. And this is tricky because that gap, in order to get patients to go from neurology or primary care or emergency department care to behavioral health care, which many people, believe to be much more stigmatized, it's hard to get patients to want to show up and see us and allow us to help them. But it's a really important part of comprehensive care, as is treating all other medical diagnoses like pain conditions or other neurologic disorders like migraines. It's important to treat all of those things. So there's a lot of ways that people describe NES, and I think about it, in its simplest form as the brain and body's involuntary stress response. So just like if you are embarrassed because you were giving a speech, you're nervous and you could blush, that's a complex physical body response that produces your cheeks to become red, but it's created from the stem of embarrassment or an emotion, which is also a complex brain process. And so some people think about this as, many people hear of fight or flight, like what our bodies do when we're stressed and we want to get out of stress. But there's also a freeze response. And a lot of times, if you think about evolutionarily, animals in the wild, sometimes they'll just not move in order to not be seen by a larger predator. And so some people with seizures have movement, some people don't, but neurobiologically, the non-epileptic seizure is more similar to the freeze response than to the fight or flight response. And so when you think about it, the body has to kind of discharge that energy built up by the stress response that's going on in the body, which is complex, has a lot of different hormone changes in the body and blood flow changes that, put our blood towards things like our muscles and our heart so that we could run away if we needed to. And so sometimes I think the non-epileptic seizure specifically is the body's way of kind of discharging that stress energy that sometimes people don't even know is there. And so other parts of, what NES is, sometimes it comes along, most of the time, I would say, with dissociation, which is basically a process in which, we all kind of use avoidance in some way, shape, or form when we're feeling distressed. So we might, distract ourselves or do another activity. And those things are to basically take us out of distress temporarily. And it usually works in the moment, kind of briefly. But when people use avoidance as their underlying main way of coping with distress, their brain often keeps upping the ante of what it does to avoid. And dissociation is kind of the biggest, most severe form of avoidance, where your brain just kind of checks out, your consciousness is lost. And so a lot of times that means that patients with non-epileptic seizures don't have any recollection or memory of having the event, and they can wake up very confused and disoriented. Many kind of where non-epileptic seizures stemmed from, historically, we used to describe that non-epileptic seizures are a physical manifestation of a psychological distress. So similar to like a blushing response, feeling embarrassed is psychological distress. And then the body has this physical response from that. And I also think about, two important pieces, especially for treatment, is that often the person is not able to express what they need or their distress with others, and may not even know it's there. And so the body is basically showing the distress in a physical way, which, if you think about, again, evolutionarily, would then be likely to bring people in to help, more likely than just dissociating in and of itself, or just feeling upset but not showing anyone that you're upset. So again, one of the reasons I'm involved in care is because a big chunk of the comorbidities or other conditions that present with non-epileptic seizures are psychiatric in nature. And the most common one I see is by far post-traumatic stress disorder. About 60% of the patients in our clinic have a diagnosis of that, and up to 90% have pretty severe trauma, but not all the patients develop full PTSD. But all these other ones, if you look at them, anxiety, depression, sleep problems, those all really, for the most part, fall under the purview of psychiatric care or behavioral health care. But some of the other really common ones that, again, benefit from looking at are pain, headaches or migraines, and then often big changes or distressing medical diagnoses, such as cancer or asthma or other illnesses that haven't yet been diagnosed and people are still kind of up in the air. So, as Larissa explained, I'm very interested in the ways in which trauma is connected to non-epileptic seizures. And so I'm going to spend quite a bit of time today talking about why this is important, why this connection is important. So trauma at the core negatively influences how our brains develop and change. And this is especially true when trauma is experienced while the brain is still developing, which is in childhood, late adolescence. And in most studies, brains don't finish developing until early to mid 20s, depending on if you're male or female. It's a little bit later for males. And so when we've been traumatized, especially by somebody who was a caregiver, it can really impact the pathways in our brain that control how we attach and relate to other people and trust, and also how we understand help, how we ask for it, how we are okay or not to receive it. And so ultimately, the brain is responding differently to stress because it's been changed or altered, the development by trauma. And so a lot of times what happens is when somebody's being traumatized, even their basic needs are not cared for or understood. And so often people who've been traumatized, they will be their needs will be ignored. And then they become an adult and they ignore their own needs and don't even know sometimes what those needs are, especially emotional needs. So even ability to express distress, have a language for expressing feelings. Those things are all underdeveloped in people who have had trauma. And so sometimes as a result, people are like, oh, well, I'm really good at helping other people. And so they become very helping others. So a lot of patients with non-epileptic seizures that I've seen have been in, care professions like healthcare providers or daycare providers or caring for the elderly. And they kind of put all that energy into not caring for themselves, but caring for the people around them. And so, what happens is when really bad things have happened, our brains can't really make sense of it, especially if it happened when we were little and we didn't have full cognitive capacity to process what was going on. And so often what many people do, and this is really a survival tactic, and again, works well at the time, but then not always later in life, is that we try to put the trauma away. We put it in a box. We try to ignore it, forget it, compartmentalize it. And that does work in the short term. Oftentimes, when NES is presenting is a time when that strategy is no longer working because the trauma often wants to be processed. And the reason for that is if you think about, if I didn't feel pain when I burned my finger on a stove, I might keep continually doing it and hurt myself. And so people who've been traumatized, their brains ultimately want to eventually remember it so they cannot be re-traumatized in the future. Subsequently, a lot of times non-epileptic seizures present around times of big changes when that person's natural coping abilities or skills are not enough for a new stage of life or a new transition. And so a lot of times I see this happening around times when people are changing jobs or they have new roles in life, like being a new parent or being married or getting a new job. A lot of times that's when the symptoms will initially present. I think this is I'm not going to go through all of this, but there are really great resources online about how trauma impacts not only mental health, but physical health as well. And many of these manifestations of how trauma can impact people is from the ACE studies, which I will talk a little bit about in the next slide. But if you think about a lot of these on here, like loss of trust, loss of danger cues, loss of sense of self, a lot of these relate to how we interact with others and thus how we attempt to seek and receive help. And that includes with doctors. And so a lot of times people have trouble accessing the care that they need, even if it's available, because of this changed pathway of how we relate with others. So if you have not heard of ACEs, ACE stands for Adverse Childhood Events. And Kaiser has done a lot of studies on what happens when people have adverse childhood events. And essentially, there are higher risk for all-cause mortality, multiple chronic health conditions, including heart and lung problems, substance use problems, mental health problems, impulsivity that can lead to things like infections, like sexually transmitted infections, for instance. And so a lot of people initially when they come, and so this was done in a study of not a mental health population, but just a population seeking primary care at Kaiser. So a lot of people often don't know exactly what abuse is. I'll ask a question, for instance, to a patient. Have you ever experienced anything you consider to be abuse or trauma? And they won't exactly know what that means. And sometimes they'll say, no, I haven't. And then later on in the interview, I'll hear something and I'll be like, does that sound like it could have been traumatic to you? But because it was normalized or it was just what they were experiencing and they didn't know any different, sometimes even really severe things, they don't label as trauma. But essentially trauma is any form of abuse, emotional, physical, or sexual abuse. Any household challenge. So witnessing your parent being abused in some way, substance use in the household, mental illness, especially if it's in a caregiver, when your parents separate or divorce, or if somebody in the home is incarcerated. And then there's neglect, which is when your needs are essentially ignored. And so again, all of this, and it's a dose-dependent phenomenon, meaning that the more trauma you've had, the more likely you are to have problems with all of these things on here, like medical problems, substance use, all the things I mentioned before. And so, you know, in that way, trauma is not just a mental illness problem. It is a complete health problem. So I'm going to talk a bit about what you should think about when you're trying to advocate for yourself to get care for NES. Because a lot of times I will share a couple kind of quotes or ideas later from patients that have kind of told me stories of challenges that they've had. But in going into a help situation, especially with doctors, it can be helpful to think about what prior experiences have you had with needing or accepting help? And it doesn't have to be medically related. And expecting that if you think about those situations, those patterns are likely to be repeated in medical settings. So this could even be, you know, getting help with homework, getting financial help if you need it, any kind of help that you need from others, emotional support, anything. If you know you've had that situation in the past, it's likely that that same kind of dynamic is going to get created when you need help medically. And oftentimes people who are traumatized have a very ambivalent feeling about being helped. They want to feel better, but they're scared to trust someone. And so if this is true, it's really helpful to share this with doctors so that they know the challenges that you've had in the past. I always advocate for more knowledge, you know, and getting knowledge from reputable sources. And it's really important as well, if something doesn't feel like it's going well, if you don't feel heard, if you don't feel like you're being taken seriously, that bringing that up earlier rather than later can be a big change in how the relationship, the treatment relationship goes. Some of the reasons that patients have difficulty interacting with or forming relationships with doctors is that it takes patients with non-epileptic seizures on average about 7 years to get a correct diagnosis. And if you think about everything that happens in that 7 years, usually they're put on medications they don't need, like anti-epileptic medications. Oftentimes they may have been to the emergency department and been potentially given lots of medications they didn't need. Sometimes that can even lead to, you know, given a certain medicine to stop a seizure that leads to respiratory depression or your lungs not working properly, and then patients needing to be intubated. And these are really serious, you know, medical complications of seizures that don't need to be the case for non-epileptic seizures. And so a lot of times people build up all these bad experiences over the years, and then they slowly are like, well, clearly doctors don't help me, so I don't trust them. But then it makes it hard for them to get the help that they do need or any kind of help to be able to get better. It can be really helpful to have write down or talk to somebody about what kinds of goals and expectations you have for treatment. You know, somebody who has a goal of being totally seizure free versus, you know, having a seizure once a week or being able to work or being able to do a functional thing. Those are different kinds of goals. And then another thing, and patients often tell me this is frustrating, but because non-epileptic seizures are not well understood by even many medical professionals, sometimes you're playing the role of trying to educate them. And, you know, I think it's always a good sign when someone's open to receiving that education from you, because a lot of times after 7 years, you've probably done quite a bit of research. And then, you know, again, being really upfront about what feels helpful, what doesn't, and then also advocating for if you were to actually have a non-epileptic seizure or your symptoms, whatever they may be in the office, it can be really helpful to make a plan for that or to express what it is that you want or need when you're actually having a non-epileptic seizure, especially as most people aren't conscious and have trouble communicating during their events. So there are some response plans that have been created, and taking kind of all those put together, our clinic has created a response plan as well that we give to patients and is also on our website. And so a lot of things that are included on this are, telling people basics about non-epileptic seizures, like it's not a medical emergency, unless somebody gets a physical injury, like breaking a bone, hitting their head, it doesn't require emergency department treatment. And then, the bottom section is really how you want someone to respond if you know anything that is helpful or not helpful. And this is very idiosyncratic, and meaning that people have very different things that can be helpful. Sometimes people want certain words to be said. Sometimes people want physical touch. Sometimes they really don't want physical touch. Sometimes, feeling warm or hot can trigger events. And so, doing something to kind of reverse or counteract that can be helpful. So those are very individualized, but having this kind of plan can be helpful in so many settings: work settings, family settings, doctor's offices. All right, so getting more into treatment for non-epileptic seizures, the best treatment so far has been found to be multidisciplinary treatment, meaning that a lot of different disciplines are involved in the treatment. In our case, in our clinic, it's psychiatry, social work, and neurology. But there are various clinics around the country that have kind of different combinations of people for multidisciplinary treatment. And the sooner treatment starts, the better the outcomes are. And it's really been found to be helpful when all these providers are able to talk to and communicate with one another. It's been shown that treatment of comorbid psychiatric disorders and tailored individual psychotherapy. So for instance, cognitive behavioral therapy for trauma, for instance, that those targeted treatments for whatever the underlying comorbidities are, improves outcomes. And then the most studied form of therapy in non-epileptic seizures is cognitive behavioral based therapy. And there's a workbook out there that was created by Dr. Kurt LaFrance. And that book basically walks through things about triggers and different concepts that relate to NES and help people recover and get better. Sometimes we use family interventions because depending on how much that need is something that requires external people or who's in the family network, sometimes families can be really helpful, family members, in knowing appropriate responses to the events and what else might be needed for that person's situation. People do really well in getting peer support in our, clinic. It's predominantly group therapy based, and so that provides a lot of peer support in addition to being supported by clinicians. And then, a couple confusion pieces. Again, kind of repeating, not going to the emergency department because likely it gets treated as an epileptic seizure, and that can be harmful. And that there are no medications that directly treat non-epileptic seizures the way there are anti-epileptic medications that do treat epileptic seizures. Some of the crucial components that I see for treatment outside of this, what I've seen in terms of the people that get better versus the people that don't get better. A big part is understanding the diagnosis and believing the diagnosis. A lot of the times I see people not get better, it's because they still think it's epilepsy, even though we have good evidence that it's not epilepsy, or they still think something's wrong that's being missed. Those are situations in which that uncertainty and that fear usually continues to drive the symptoms. Having good support from family and friends, and also family and friends understanding and believing the diagnosis can be helpful. Being open to discuss it with other people and explain it to other people. So not hiding it or being embarrassed, even though many people feel embarrassed in the beginning. Feeling like you're being helped and getting good treatment. Ability to trust medical providers. being open-minded. A lot of people come in and they're like, what? I have to like sit and talk to a group of people to get better? That doesn't sound like it's going to work, you know? But being open-minded, because sometimes people get very surprised that, you know, it was more helpful than they thought it was going to be. We already talked about, you know, treating underlying psychiatric comorbidities, overall becoming more aware of your own experience. And this often happens through mindfulness, and a lot of treatment for non-epileptic seizures in other places is through mindfulness. And that's a big part of the cognitive behavioral therapy treatment as well. Because ultimately the goal is to become more connected to your experience and learning when non-epileptic seizures are occurring and why. And it's important to know that this diagnosis is not something where we can just give you medication and you get better. It requires really active involvement from the patient. I kind of think about this, you know, metaphorically as I'm like the guide up a mountain, and, you know, I can lead you, but you're the one who has to walk up that mountain with your own legs. So it takes a lot of active participation. Patients often don't connect why therapy is an important part of treatment for non-epileptic seizures. And I think about this in a few different ways. One is, you know, we have pretty good brain research and data showing the brain can change in its structure and its function in response to experience. So a very simplistic example of this is when they study violin players who, you know, have to use their left hand in a really intricate fashion. And they study their brains. The area of motor cortex that represents the left hand is bigger than average. So by playing the violin over and over and practicing, they have grown a part of their brain, or they have expanded the function of that part of the brain. And so the same thing can happen, but just in a much more complex fashion with some of the concepts I've been talking about previously. Humans, you know, we like doing what's easy and what's automatic. And so any change, whatever that change is, in order to get better at it, we have to practice. And that includes asking for and receiving help. Oftentimes, even just the diagnosis and the symptoms of NES can be experienced as traumatic in and of itself. And so that's stressful and a situation in which more support is needed, and which can happen in a therapy setting. And then, you know, the body ultimately, because it's trying to communicate a need with NES, therapy is a place to learn how to communicate with words and to practice that. And so the better people can become at communicating their needs with words, the less likely it is that their body will need to do it for them. And ultimately, the kind of big picture of treatment I think about is if you can understand for yourself why the non-epileptic seizures developed, you can work on more effective ways and safer solutions for meeting whatever those needs are, which often are a better shot at being safer. Many people want to know, will I recover from non-epileptic seizures? And just like many other medical diagnoses, you know, prognosis is unclear. We don't know exactly what causes some people to get better and some people not to. We have kind of correlations, but not causations for those things. With appropriate treatment and engagement in treatment, some patients have remission. More commonly, patients have decreased severity and frequency of the non-epileptic seizures, but continue to have symptoms. There's a few good prognostic factors, meaning factors that make it more likely that people are going to get better. Like being younger or a child, having the illness for a shorter amount of time, not having as severe psychiatric comorbidities, functioning in other areas of life, such as working or relationships. And then some of the poor prognostic factors, or things that make it less likely to get better, are having comorbid epilepsy, psychiatric diagnoses, violent seizure activity, a dependent lifestyle, and poor relationships. And while not all patients can completely get rid of symptoms, there have been improvements shown in other areas of life with treatment, such as quality of life is better, not feeling as distressed, having bigger chunks of time between seizures. And interestingly, in a lot of these studies that have been done on this topic, The quality of life in patients with non-epileptic seizures is more related to things like mood, anxiety, and how they perceive their illness than it is to how often they're having seizures. And lastly, I said I would share a few things that patients have reflected on over my about 6 years of treating patients with non-epileptic seizures. And these come up time and time again. So it's not just one patient, but many patients who've expressed these things to me. One was having to acknowledge past trauma. And even though that was a painful process, that they needed to do it in order to get better. One was that they needed help and they recognized in hindsight they weren't willing to accept it before. A lot of people had to kind of weed out toxic people in their life and know who was really there to support them. I would say almost 100% had to learn better ways of talking about and understanding their feelings and emotions. Almost everybody feels that they previously were ignoring or avoiding all their problems, and that was what caused the non-epileptic seizures to start in the first place. And they need to learn to face up to those challenges more directly, even though it can be painful. Getting validation, being able to validate yourself and validate others and have self-compassion. Those are important parts of recovery. And that they notice that they have loving people in their life that wanted to help but didn't know how to help. And again, I kind of mentioned this earlier, that people notice, oh, I'm really good at helping others. So if they can only just turn that helping kind of strength toward themselves, those people tend to do really well and get better. And just, this is the last slide that these are a number of resources that I very typically give to patients that I think helps in understanding trauma and understanding, brain changes in response to therapy. The workbook I mentioned for non-epileptic seizures, and then our clinic website for our multidisciplinary clinic at the university is this nestreatment.org. And we have a lot of different resources and websites on that as well. And I didn't put, this is not a comprehensive list. So these are the references I used to put together the presentation. And I thank you for listening and being interested, and I'm happy to take any questions that people have.